Okay, hello. Hello, everyone. I don't know what happened with the mic. Anyway, I'm just gonna mention some things that I wanted to share with you and the situation that I believe is important for you as a therapist and knowledge of female reproductive system. I would ask you just go with each of the slides just to know anatomy and specific features about the ovaries for the sex cord cells, the oocytes, and what happens with the specific phases of the menstrual cycle. Read and understand again, because this is basic science from physiology about the hypothalamic pituitary ovarian axis. I'm not going to go through it, but it's important that you understand why those hormones are going to be produced or stimulated from the part of the hypothalamus into the pituitary, and how the FSH and LH are going to those specific organs, either between the ovaries and going to the breast in any way, depending on what stage and what condition you're talking about. But important to understand which one will occur by what cells in particular, and what hormones are being produced and released for maintenance of that pregnancy. We already went through some of the infections. I'm not going to go through them. A little bit of hormonal disorders, benign and malignant tumors, and the one that I left out was the disorders related to pregnancy that I'm going to talk a little bit more. So review again your knowledge of the normal menstrual cycle. Think about the phases that happen those 28 days, and what's happening as how they call it for the ovary in particular, those levels that are going to be as LH and FSH in the ovarian cycle, that for the in the endometrium, what changes are going to be happening, considering each one of the two hormones being produced, and then what happens within the endometrium. So estrogen and progesterone levels are important, and what happens with the endometrium for this to understand it better. Some anatomic changes or important things to know is the parts of from the external area into the vagina and into the cervical area, uterus, and how things are related here. You can go to your anatomy class 2 and review all of these structures. Probably the only thing that I'll mention here is that in etiology for inflammatory diseases, the most common ones in most of the population will be Trichomona and Candida, but the STD pathogen that is the most common one is going to be chlamydia. Even though Trichomona and Candida can be related with as sexual transmitted diseases, it's not necessarily the most common one. Chlamydia would be the most common one. Viral, herpes, and HPV are the two to be really thinking about always. Read on each one of these as genital herpes, the vaginitis, and chlamydia. Like I said, vaginitis is going to be basically by the Candida and Trichomona, but they have a specific features as how it comes, and typically this is more related with hygiene and pH related than, and obviously with sexual activity. But the thing is, as a sexual transmitted disease is going to be chlamydia, the number one, and also herpes is related as HPV. Now, the human papillomavirus, the presence of warts is going to be giving the main characteristic and the formation of condyloma acuminatum. Remember that we talked about syphilis having condyloma latum. Here is acuminatum. It just means that it's having kind of a crest there, not flat. Gonorrhea, syphilis, and PID. The thing here is that gonorrhea is going to be typically considered to be not the infectious type that is going to be versus the chlamydia that is going to be with infertility and having babies with pneumonia and conjunctivitis. This vaginal discharge also is important along with vaginitis and cervicitis. The inflammation that this bacteria causes is going to bring dysuria as one of the main situations. In gonorrhea is another type of secretion that you're going to have, but typically here the baby that is born from a mother that has gonorrhea, typically just conjunctivitis, purulent conjunctivitis will be the main situation. Also, the presence of dysuria is also there. Here, treatment with an antibiotic will cure the situation. Syphilis is a spirochete is a Treponema pallidum, and this follows the 3-stage as Lyme disease. Syphilis is a 3-stage condition. The first and second, I think we'll review it. Penicillin is very effective to treat and cure this condition, but if left untreated, it goes to either a secondary and third stage, and that's when central nervous system and the joints are affected, of the heart is affected. In PID, situation is that it's very related, it's very common and frequent to have ectopic pregnancies, and most likely infertility is the main situation here. So some of the hormonally induced lesions that we were talking here is just non-ovulation phase, and this can be because there's either a functional situation and is more common than an organic situation. High athletes or anxiety will also tend to have anovulatory type of cycles. Early menopause, some pseudocyesis, which is the imagined pregnancy, and anorexia nervosa or bulimia are related with this too. But the most common cause is puberty, where the hypothalamus is not established yet. If you have hyperestrogenism, it means that there's a lot of estrogen being formed, and the most common cause could be because of injections or pills, and endogenous is related with tumors. So whatever happens with hyperestrogenism means that there's endometrial hyperplasia. So a lot of estrogens. So this is what happens with the endometrium, that the estrogen and progesterone phase never sheds for regression as normal and then having menstruation, but excess estrogen just follows and increases the tissue of that endometrium, considering a hyperplasia. Hyperplasia, if it's remove that and control whatever factor is causing it with medication, typically it goes to normal, and this is very common. But if this keeps on going from hyperplasia, goes into metaplasia, eventually that metaplasia, if not taken care of, goes into dysplasia, and from dysplasia to anaplasia, and that's when the adenocarcinoma is considered to occur. So some tumors, we're not going to go through all of them, but the most common thing or the most important factors is that typically you're not going to see anybody under the age of 35 with tumors of this type of nature. If there is, there's typically going to be a benign tumor. So benign tumors are common, like I said. The smooth muscle is the most common type related to this. Some other types of cancer, as the vulva for older women, squamous cell carcinoma is going to be the type of tumor because of the type of epithelia that you have there. Itching, discomfort, pain, and bleeding are the main conditions. Cervix is going to be related with HPV infection. Very important to know this. And I remember mentioning in class that smegma happens to be one of the major factors here. So hygiene is also important. So early age, sex, multiple sexual partners, evidence of this HPV infection, and has some herpes or syphilis also, and smoking tobacco has been also known to be related with cervical carcinoma. So transformation of this squamous cell carcinoma is going to be happening where that squamous epithelium meets the columnar or glandular type of epithelium of endocervix. And this is preceded by dysplasia and carcinoma in situ. And then once this happens, like I said, but not necessarily, I mentioned in the endometrium, but here it's the same thing, from a dysplasia or from a probably a hyperplasia that was happening. From hyperplasia went into metaplasia, and then went to dysplasia, then it goes into carcinoma in situ, finally goes into invasive carcinoma. The only way to really detect this is by pap smear. Any blood tests or other type of exams may be doable, but they're not going to render any type of a specific diagnosis. And prognosis, it just depends on the stage of the tumor. This is an image for you to follow, where from a normal tissue to changes that they might be from the cervical intraepithelial neoplasia 1, 2, 3. You see that the basement membrane, once it's invaded, then it changes its name to become a carcinoma in situ. One that invades the beyond the basement membrane is an invasive or stage already thinking about having metastases. So staging, it just talks about the levels where you're going to have from the cervical area, from no gross lesions, having just that in situ, going into cervix for 1, beyond the cervix, and spreading to other organs, metastasis stage 4. Every tumor, stage 4, typically means there's some metastases or infiltrating other organs. Again, 50 years is the median age, nothing before 35, but you can have changes in that level of the epithelium, and it takes about 15 years to invade, so there's a lot of time to really do something. And typically either you're having a symptomatic situation, if it's not that invasive or it's not that acute, or probably you have some bleeding, typically post-coitus. The discharge is typically going to be blood, or could be some sort of purulent, even have foul smell, but this has to be related with some sort of bacteria also included here. So prognosis, if it's a CIN in any stage, typically you're going to have a cure, but it's already a stage 4, less than 15% for 5 years. When a colposcopy is done, that's the view of the cervical area through the vagina. This is a normal type, a normal cervix with a smooth surface, but when there's an invasion and there's some high intraepithelial changes, which is an neoplasia, you're going to have all this type of irregular surface and ulceration of the surface of that cervix. Uterus will have 2 types of tissues, endometrium and myometrium. Important thing to remember when we talk about neoplasias, endometrial tumors all are malignant. There will be no adenomas as benign. The other thing is that the muscle layer will have either leiomyoma or leiomyosarcoma, the benign and malignant condition. Endometrial tumors are glands, so adenocarcinoma is going to be the common denominator here. And the most common of the tumor of female genital tract, which is accounts for 50%. Hyperplasia means just the changes of that gland, the possibility of becoming malignant. So some atypia following that hyperplasia will lead to adenocarcinoma. Endometrial adenocarcinoma has to do with certain features, like probably having some sort of overweight. These are tumors that will be producing estrogen, or they're taking estrogen as pills or injection. And typically they are preceded by endometrial hyperplasia. So people that have not been pregnant or had an early menarche, typically those are more at risk, and it occurs typically in older women, either perimenopausal, then into postmenopausal. Pregnancy is understood as regulated by progesterone to hold the egg and plant it. So endometrium rests from that estrogen stimulation. So pregnancies will reduce the risk of endometrial cancer. Not that I'm suggesting anything, but some prognosis that will be variable depending on the stage. Like always, the earlier you can detect something like this, will have a better chance for survival at 5 years. Typically, we'll start with some sort of exophytic polyps, and they tend to bleed, but some will have an endophytic, and they invade myometrium, and that's a little bit harder to detect. When there's some ulcer or type of, not fungal type of lesion, but just the shape of a fungus or a mushroom type of lesion inside the lumen will be easy to find because of bleeding. Invasion to the myometrium is typically going into the serosa in time. Metastasis to pelvic lymph nodes, that's going to be the stage 4 of it anyway. So depending on that staging, this is the survival rate. So you'll have basically the same as you can follow this chart or this picture. It's rare before the age of 35, more typically in women entering menopause. There will be some vaginal bleeding, and this is the most prominent sign more than symptom, because it's something that you see. And the only way to really detect this will be through biopsy. A hysterectomy, which is the removal or resection of the uterus as a treatment by staging. Some radiation and chemotherapy can also be applied. The myoma of the uterus is the benign tumor of the small smooth muscle. So thing here is that it's important to know this will not be a precursor for malignancy. And this is something that many women will have and find through some failed pregnancies, because this is going to be an irritant in some way. So having a leiomyoma sometimes has to be removed. Some smaller size will be asymptomatic. Some mass effect will be also happening. Some can grow so big that they will have some sort of either urinary symptoms or constipation or even abdominal heaviness. They've been known that some leiomyomas have been brought out and thinking that even the patient was pregnant, and those tumors have weighted over 10 pounds. The term of endometriosis is one of the most common, or one very common situation in some women. 15 to 20% happen in reproductive age. Pain, peritoneal irritation that happens over menstrual cycles. And the thing here is that these, there are foci of endometrium that found outside the uterus. So endometrium should be only inside the uterus, but when this type of tissue goes out, anytime that there's a normal menstrual cycle, they're going to bleed. So those cells are going to grow, and eventually there's some cell proliferation to secretory phase, and that's going to have some bleeding. This is a cell-limited disorder, and typically will not progress into cancer, but they're very painful, very uncomfortable. They might lead to some infertility, and the nice thing about it is that it can be treated with some contraceptive pills. The ovarian cyst is a very situation, a very not common situation, even though it says here common, but the thing is that the truth of the matter is that the ovarian cysts that might happen have to go also with ovulation that is ruptured. And the solitary type is the most common presentation. 2 types, one the follicular cyst, when it doesn't rupture, keeps that fluid inside. That's probably the most common things and the most typical feature as pain goes. What happens is that it should go to a corpus luteum cyst that it typically has to involute after ovulation. But here it just remains, and the fibrotic corpus albicans, a white bodies for fibrous, and it remains with fluid in the cavity. So that corpus luteum would form a cyst. And there might be a multiple type. This has to do with some other abnormalities or features. The ovarian neoplasm, the type that you've heard from one of the former U.S. gymnastic champion is an advocate for this. The thing here is that most of these tumors will not give more signs or symptoms than abdominal pain. Some might lead into, obviously, if they're in an age of reproductive age, they will be probably infertile. Some type of cancer happens in some specific situations, and others, like Turner's and use of contraceptive, will not develop into ovarian cancer. Some cells that will origin this are listed here. The surface epithelium is the one that's going to be the most consistent as having this neoplasm. So the thing here with a germ cell tumor of ovary is that it's typically in women before the age of younger than age 25. Teratoma, the most common germ cell tumor, is benign, but the malignant tumors of teratocarcinomas are going to secrete these two markers as alpha-fetoprotein and human chorionic gonadotropins as markers. So this hormone, as in pregnancy, is excreted in urine, so you're going to be able to mark it. If you're not pregnant and you have a high level of HCG, think about having some tumor of the ovary and for this matter. And same thing, in men, if you have a testicular germ cell tumor, you're going to have a positive pregnancy test in men. And when this happens, it means that the testes are producing HCG because you have a germ cell tumor. So those are important things to know. And sex cord stromal tumors, I'm not going to go into them, but some of these tumors are dependent upon the layer and the area where they are located. So just 5% of all ovarian tumors will have this type of tumor. So it's just important to know why they're called and their existence there. Metastasis to ovaries, typically endometrium and breast are going to be the two areas where they send metastases to the ovaries. So these tumors have estrogen receptor. So again, if you have osteoporosis, you get a treatment of estrogen, most likely you're going to have an increased chance of developing this type of tumors. And from the GI tract, metastasis to ovaries is very also common. And the most common one is from gastric carcinoma to bilateral enlargement of the ovaries. These are called Krukenberg tumors when it comes from the stomach. So the pathology of pregnancy and fertilization. 4 type of factors that will prevent fertilization, either from the egg or the sperm, genital organ related factors, or systemic factors. If we start with the systemic factors, have to do with immune mechanisms. Some antibodies to sperm or ova, and this will prevent fertilization or implantation, and obviously the development of placenta. If you're talking about genital organ related, think about PID, the pelvic inflammatory disease, that 30% will go with infertility, and typically it's a fallopian tube pathology where most likely is going to be affected. When there's sperm-related factors, either no sperm is produced or the quality is bad. When it's an egg-related, an ovum-related, which 20% will not fertilize, these are typically because they're either immature, by incomplete meiosis, and if something happens at this stage with this situation, you know you're going to have some problems as genetic things, and the most typical one is Down syndrome for this. And older women have an inferior quality of that ovum. So implantation takes something like 6 days after fertilizing that ovum by the sperm to reach uterus, and has to have some hormonal changes up to that moment, so the egg can be implanted, typically either in the fundus or the higher levels of the uterus. If for some reason something happens and there's an ectopic pregnancy, it's just that the fertilization was outside and somewhere around this area or this area, not inside the fallopian tube. But interesting, some of this type of ectopic pregnancy, 95% happens within the fallopian tubes. So placentation means two situations with a placenta. The trophoblastic membrane. So the placenta accrete means that the placenta villi into the uterine wall has a deep penetration. It's not considered normal. There's also going to be an absence of that decidual membrane that gives a normal bleeding for the placenta. And this absence is going to be implanted into the muscularis, or the muscle layer. So placenta accrete has to do with the implantation of the placenta inside the muscle layer, not where it should be. At birth, that placenta will not shed normally. So there's going to be a massive bleeding from that muscle wall. So think about accrete in some way not being a normal implantation, but goes into the muscle. So when the baby is born, the normal placenta that should be there at the decidual membrane, that should normally bleed when it's born, the baby is born, is going to have a more bleeding, massive bleeding from muscle wall. And this is sometimes uncontrollable, and a hysterectomy has to be done. Now, when there's a massive bleeding, there's going to be an endocrine type of problem, which is called Sheehan syndrome. And that's when Sheehan syndrome talks, there's in the hypophysis, in the anterior portion, is a necrosis at that level. So you're going to have huge problems. Placenta previa means that the implantation is not in the upper part of the uterus, but the very lower segment near the cervix. So anything that happens around that area when typically at the third trimester, week 32, 33, 34, 35, the baby's gaining weight, that pressure at the os, where the cervix is, just gives away, and probably that starts bleeding. This is a situation where sometimes U.S. therapists, you have to be careful. If you give some exercises for a woman that's pregnant and might have some placenta previa, and you give some exercises as abdominal and some increasing abdominal pressure, like it's Valsalva maneuver, what this thing is going to cause is an early opening of the cervix because of pressure inside that uterus, and a placenta previa is going to happen. So part of the placenta, this disc over the internal orifice of the conduct of the cervix, is going to start a massive bleeding during delivery. The thing here is also danger for fetus and mother. A C-section has to be done, cannot be born through a normal vaginal delivery. Abortion, probably just some concept, interruption of pregnancy before the term of that fetal viability is the definition. 20 weeks gestation and more is going to be considered abortion. Before that time, probably not necessarily. 500 grams over a pound is going to be also considered part of the abortion definition. There can be an induced type of abortion, either by request or some indication and performed by a gynecologist, or it can be a spontaneous, and this can be complete, incomplete, a missed or threatened type of abortion. This is the one that typically many women have, and pregnancy must continue or may continue. If it's over 20 weeks, some of them will, if they had a spontaneous rupture of membranes, the baby has to be born. So that's the prematurity of some cases. Observation and rest is very common in the first trimester of pregnancy because of a threat in this manner. Some gestational trophoblastic disease, probably two terms. The mole, hydatidiform mole, which is a benign presentation of this type of placentation. This is about the trophoblast. Remember, the trophoblast is going to form the placenta. And there's a choriocarcinoma, which is the malignant form. So there's a benign presentation and a malignant presentation. And 50% develops from this mole. So the presence of benign presentation, 50% will develop into choriocarcinoma. Most of them have good prognosis. Some antagonists of folic acid can be given. Cure could be from 80 to 100%. This is a mole, typically is just a degeneration of the chorionic villi. Complete mole, so fetus cannot be identified. Incomplete has attached to it some fetal parts. Typically, the presence of a mole will give an abnormal fertilization. So all chromosomes are for the paternal origin, and this is called, the process called androgenesis. And just a review of how these complete or incomplete hydatidiform moles are present from androgenesis. This is two examples, maternal and diploid paternal chromosomes, and bispermy, when two chromosomes reach one X and one Y, the same ovum, so there's going to be a triploid type, but again, comes from the paternal side. The thing is that most of these will end up with a spontaneous abortion in mid-pregnancy. And again, it's not for you to know each individual situation, but just at least know about them. Finally, toxemia or eclampsia pregnancy happens to do with three things. You have hypertension, edema, and presence of protein in the urine, proteinuria. This typically will happen about after the week 34 of gestation. Nobody really knows the cause, but the thing is, has to be with some release of cytokines as the best example or explanation of this. This triad of high blood pressure, edema of lower extremities, and protein in urine is called preeclampsia. The presence of seizures, convulsions, is going to be called now eclampsia, but it has the three as preeclampsia. Just adding seizures to this, it's called eclampsia. Typically, once the baby is born, there's good prognosis. You can control it, obviously, through pregnancy, and 6% of them will develop some sort of preeclampsia, and less of that into eclampsia. I haven't seen one in 20 years, by the way. So thank you, and we'll finish this one. Bye.